So I'm very excited to share with you a glimpse of the new guidelines. Now, if I show this to you, I have to shoot you at the end of the session because it's not published. So anybody, so wear your glasses so you can't see this. So what are the new guidelines in 2025 going to say? And for example, do you need left atrial reservoir strain to help you in this indeterminate case? So Leonardo's case was very interesting because he had some features, perhaps the L wave, but there was some bradycardia, but the pro-BNP was low, so it wasn't very clear, and it's a very good case. So these are my disclosures. In the next 10 minutes, I'd like to give a general introduction, briefly talk what are we measuring in terms of the physiology, what are some of the problems with the current 2016 guidelines, show some quick cases, and then give you a glimpse of the 2025 guidelines. As you know, back in 2009, actually we did this course 2009 and we presented the guidelines, but there were too many parameters, too much overlap. And then in 2016 we updated those, and I even wrote a president's page. Diastology, what does the new updated guideline do for you? And this led to debates online at ASC Connect. Somebody wrote, I had a discussion with a cardiologist who doesn't believe in the assessment of diastolic function. On the other hand, somebody said diastology finally makes sense. A big thanks to the writing group. So there could be some fistfights about this as well. But some of the troubles with the 2016 guidelines, often you're missing data. Like, for example, you're missing the TR. Some of the parameters don't add up. There's some conflicting parameters. Big debate, who's in algorithm 1, algorithm 2, uncertainty, who's in or not. What's the association with the HFpEF? And this epidemic of indeterminate findings. And you can see here in 2018, they compared the 2016 to 2009 guidelines, and they showed that roughly 15% of the people had indeterminate so-called diastolic dysfunction measurement. So let's remember what we're measuring. For example, here's the LA pressure, LA volume pressure curves. What we're interested in is we're measuring mean LA pressure or pre-A wave pressure and not necessarily EDP. EDP is the first one that will be elevated, followed by the mean LA pressure or pre-A wave. So that's the important thing. The other things that you want to decide when you look at the mitral inflow and tissue Doppler in relation to the LV filling pressures, for example, this is like grade 1 diastolic dysfunction, prolonged relaxation, prolonged IVRT, a low tissue Doppler. This is a normal LA pressure, mean LA pressure situation, versus somebody with restriction, with somebody with amyloid, very rapid filling phase, big E wave, short deceleration time, short IVRT, high EA ratio, and low tissue Doppler. So these are the two extremes that we have to measure. In the 2016 guidelines, the committee, the writing committee, says let's use things that we use on an everyday basis. For example, the left atrial volume index, EA ratio, the tissue Doppler E prime, and the TR velocity. So when you look at the current guidelines as of today, you ask two questions. One, is there diastolic dysfunction or high likelihood of diastolic dysfunction? And if so, how do you estimate the filling pressure? So currently, as we speak today, so when we have a patient, most patients will have this in their echo labs. If they have myocardial pathology, for example, extensive cardiac history, a wall motion, CAD, LVH, amyloid, known HFpEF, reduced EF, or an L wave, there's myocardial pathology, and therefore you use a so-called algorithm 2. And algorithm 2 basically is the one that most people would use in most labs, and you divide that into a low EA ratio or a very high EA ratio. A low EA ratio with a low E wave will have normal LA pressure, grade 1 diastolic dysfunction. Somebody with amyloid, very restrictive, will have a high EA ratio, and this will be grade 3 diastolic dysfunction, high LA pressure. Where it gets a little more complicated is in between, where you look at these parameters, and if all are positive, 2 are positive, this will be grade 2. If all are sort of negative, they'll defer back to the grade 1. And in between, you have perhaps indeterminate, and you have to use other things. So what if everything looks normal? So you have to know a normal situation. So then you would use algorithm 1, which is quite unusual. If everything is negative, this is normal diastolic function. And if everything's positive, this is diastolic dysfunction. And in between, 2 positive, it's indeterminate. Most echo labs should try to report out what they think the filling pressures are. Are they normal or elevated or can have to be determined? Or what the grade is, grade 1, 2, and 3. So here's a typical case that we would see, a 60-year-old female with shortness of breath. And here's the parameters. You can see the EF is not normal. LAV is 80, very large left atrium. The TR is more than 2.8, so that's elevated. EA ratio is 2.2. And the ED prime is borderline elevated 13.3. Then you throw in some strain. What do you see here in the strain? This is apical sparing. And you can do left atrial reservoir strain. Now, left atrial reservoir strain stands for my chief at Cleveland Clinic. His name is Lars. So he likes when I tell him that you have your left atrial reservoir strain is so-and-so. But anyways, this left atrial reservoir strain is 3%, which is very abnormal. So therefore, this patient has a high EA ratio and grade 3 diastolic dysfunction. So this is quite straightforward. It's shown with simultaneous cath lab type data. So there is emphasis now on using other parameters, for example, LARS or LA pump strain. This is from Dr. Smyseth. And now the algorithm 2 should have LA reservoir strain, and a cutoff of 18% is usually the cutoff, especially for indeterminate. If it's indeterminate, it's less than 18%. This will show that's more severe than it is. If it's more than 18%, that's good. You hear from Amy very shortly about when not to use this. This will be in the special populations, for example, AFib, bundle branch, severe MR. Okay, now we have fistfights. These are the giants of diastology guidelines. Literally, every day there's 20 emails from Mayo Clinic, from Rochester, from Houston. Cleveland is sort of like the tiebreaker, and then we have Oslo. So these guys, including myself, are trying to figure this out. So you have to shut your eyes. These are this is the rendition. So this is what we came up with. So basically, it was too complicated. We tried to merge everything. Now we have a stepwise approach. So we're looking at E prime, and this is based on large data sets of 1,000 patients. So we have different cutoffs. So E prime, we use that as the first step. So is that low or normal? So the cutoffs are a little bit lower based on age. So for example, everything's septal less than 6, lateral less than 7, or the average is now 6.5. That's abnormal. Okay, so then you go to step 2. As there are markers from LALV remodeling, elevated pressure. These are the typical things that we have, the EV prime, LARS, EA ratio, and LAVI. Also, you can throw in LV mass here. And if you have low E prime plus one more, you have diastolic dysfunction. If you have E prime is preserved and 2 or more, then you have diastolic dysfunction. Okay, so this is the one algorithm that we have now is basically if you have reduced E prime, high EA ratio, and TR. Similar, if all are normal, this is normal diastolic dysfunction. If everything's positive, now we have increased LA pressure based on your EA ratio. If it's less than 2, that's grade 2. High EA ratio, more than 2, this is grade 3. In between, so the committee looked at if you have only 2 of the 3 abnormalities, then you need other things. For example, pulmonary veins coming back, left atrial reservoir strain, as I mentioned, LAVI, even IVRT. If this is positive, then it defers up here. If these are all negative, then it goes down here. Also, if your E prime is abnormal, then you decide based on EA ratio. Sounds complicated, but here's a case. Here's a 73-year-old that Jen helped prepare. So there's history AVR. And basically the dimensions are pretty normal. There may be a wall motion, so we're not so much looking at ejection fraction anymore, but we're looking at the stepwise approach. So once again, here's the stepwise approach. So here's the stepwise. So E prime, sept is less than 6, so that's definitely a positive. The E prime is 15, so you have some marker LA remodeling. So you have 1 plus one other parameter, so you have diastolic dysfunction. And also LAVI is 40, which is abnormal as well. Okay, so step 1 plus step 2, you have diastolic dysfunction. Now you use the algorithm, and as I mentioned, 2 of these things were positive, so therefore you go to the purple box. Is there anything else that's positive? And we found that the LAVI was more than 34. So based on that, you have one positive. Then your EA ratio is less than 2. So therefore, you have grade 2 diastolic dysfunction. So this is preliminary, and this has now been looked at very, very carefully. So in this case, there's increased LAVI, EA ratio between 1 and less than 2. So grade 2 diastolic dysfunction. So the take-home points in this very short view. So basically, you have use EA ratio, annular E prime, EV prime, LAVI, RVSP like before. But now pulmonary veins making a comeback. Left atrial reservoir strain is important. IVRT is important. Use a stepwise approach. These cutoffs are based on large data sets. Ties into HFpEF, and hopefully should be published in 2025. So once again, I have to shoot you at the end of this presentation, so don't tell me. So if you didn't understand anything, you can buy the book. There's a book on diastology. And thank you so much for your attention.